Good afternoon, ladies and gentlemen. Welcome to the plenary session of the EAO.
Good afternoon, dear friends. It will be a beautiful afternoon, I would say.
Yes, so this afternoon we have been very demanding to our speakers. So thank you very much, because it will be a very interactive session, a little bit different than what you have seen or heard today. We will be talking about quite a difficult topic, but it is a topic that we are facing on an everyday basis. And we wanted to replicate the ideal scenario of a dental practice on Monday morning with an interdisciplinary approach. So we have the luxury to have the periodontal view, the surgeon view, and the prosthodontist view on something that is really, in a way, difficult to approach, right, Francesco?
Yes, absolutely. And we are going to assess really the most difficult clinical scenario, I would say, that is, again, the failing cases.
Yes, so the borderline cases. So we will be talking about those cases where you are in doubt of whether to start again and tell the patient, I'm sorry, you have a failing case, so we need to completely start from scratch, or perhaps find solutions from a pragmatic or conservative point of view to keep unresolved. So if we can have the initial slides. Now, it is important to try to focus and understand what we are talking about. And when we're talking about failure, first of all, we wanted to address the aesthetic area. We've been hearing and talking a lot of this, but I think it's the most important because our patients are socially affected by the aesthetic area as well as functionally. So when we talk about failures, Francesco, is it true that we can define what is an implant failure in the aesthetic region, and what do we see on our patients? It could be an infectious disease, so an implant that unfortunately has a periimplantitis, diagnosed as periimplantitis, correct? We can obviously talk about an aesthetic failure, and unfortunately, most of the times aesthetic failure is an impairment due to a malpositioned implant. And of course, a functional failure, an implant that is unrestorable. And often, the last two, the aesthetic and the functional, are joined together. Am I correct?
Absolutely. And
for example, these are cases that we see on an everyday, well, not on an everyday basis, I hope, but unfortunately, these are cases that come to our practice. So if you have a patient on Monday morning with a case like this, what do you do? Or an implant that has been positioned well, but unfortunately presents a fistula. So there is a problem underlying there. And perhaps probing that. We're periodontists ourselves, so we know that this is a dangerous zone. Or even worse, this is specifically referred with, this lovely patient came to the practice saying, I have the appointment ready for the restorations to be positioned. But I think that something is wrong, right?
yeah, absolutely.
So these are the typical cases where we are going to ask our world-renowned speakers how they would treat these similar cases. Each one of them have brought one case, and we will interact and discuss as if we were a team. Now, Francesco, would you like to mention something about the periimplantitis?
Well, and when looking at the clinical scenario of periimplantitis, yes, we are facing with really a nightmare, because we have now clinical guidelines for a proper diagnosis of periimplantitis, but unfortunately, we have clinical guidelines for treatment of periimplantitis, but the evidence seems to be sometimes controversial. So really, we don't definitely know what we can do for saving implant with periimplantitis.
Okay, so I suggest that we ask our first speaker, who is an excellent prosthodontist, right?
Periodontist.
And
Periodontist.
Sorry. What did I say? Periodontist, I'm sorry.
We are creating, a crisis in Jose Nart.
Absolutely, absolutely. An excellent periodontist. And to show us a case that he has treated with difficulty, I would like to say, and how, if you would like to present to us our case, and then from then on we can discuss on all the options available.
Professor Jose Nart from University of Barcelona. Welcome.
Thank you. Thank you. Thank you, Isabella. Thank you, Francesco. I feel very fortunate being here this afternoon, and I really want to thank the EAO for inviting me. Yes, I'm presenting the case of a young lady that wanted to improve her aesthetics, and along with my brother Luis, we tried to do our best. But I'm involving today in the discussion the panel of speakers here, and with all of you, we'll see what we did is what is the gold standard, or we had some other options with hair. So now is around 30 years old, and she's, as you can tell, having a little bit of a mess in the front area. She's having anterior agenesia and too early placed implant in the position of the lateral incisor. She's missing 13 and 12 as agenesia, and before she finished her growth, she had the implant placed, which is the gingival margin, or mucosal margin, better set, in a more apical position that we would like. For the rest of her mouth, she's okay, and she has, so what we would say, localized plaque-induced gingivitis and a peri-implant deficiency slash dehiscence. And so I'm not talking about today about anything related to bacteria, but probably a misplaced implant with some local related factors. This is a closer view in which you can tell that it is not only shocking the position of the implant of the lateral incisor, but also asymmetry and, of course, the inflammation surrounding the implant and something else, misfitting restoration. So it is not really a beautiful scenario for hair. If we look into the details of the implant, as we have to decide if we save it or we extract it, save it and treat it, you see 3D, the 3D position in terms of the buccal angulation or placement is not too bad. I mean, it's not bad. In fact, it's exiting the cingulum. But it is true that apically position, the apical position is probably too apical. And, well, you can tell, and this, of course, worries me, there is a little bit of attachment loss distal to the central incisor. And the other peak of bone has also, or seems to have a little bit of attachment loss as well. And this is the issue we're having. But there is presence of buccal bone to the implant. And this is basically where we are. And this is the information we gathered at the beginning. And so I sat down with my brother Luis, the prosthodontist, and I said, Luis, what are the options we're having? And what do we do?
Okay. Can we have the mics on? Okay, fantastic. So if you can switch on the mics for all the speakers, thank you very much. Now we will, so this is our case, right? On Monday morning, we sit down, we scrub our heads and say, can we have the last slide on of Professor Nart, please? The last slide that he was summarizing the case. And can I please suggest the audience to send questions, because we have the iPad that we can check on a regular basis, and we will try to answer. So now, before he shows us how this case is treated, Jose, I always ask my patient, if I had a magic wand, what could I do for you? What is her chief complaint? Because we need to think of the patient, and we put the patient in the middle.
She clearly stated that she didn't like her smile. And I said, but is it about this lateral incisor? Is it about the implant? She said, not only. I have spaces, I have poorly fitted restorations, misalignment, but yes, certainly the gum is high surrounding the implant. And I hide from smiling, which is very sad in a young lady.
Vivianne, do you notice anything in terms of soft tissues? I mean, what would you say? I mean,
yes, so I think we have here, I see two issues with a large soft tissue deficiency in volume. I saw actually that the bony situation is not too bad,
Yeah.
and the implant positioning is also okay, but we have clearly a soft tissue deficiency, and also the space alignment. I'm not sure, is the canine missing? I didn't.
Yes.
Oh, so we have a missing canine. So this speaks that we have also a problem with the alignment, probably of the midface, why
Exactly.
the patient is not happy.
Bilateral canine agenesia and also right lateral agenesia as well.
Okay, so if you look at the case, then I have two questions. So we approach it locally, only looking at the lateral incisor, or we bring all the teeth into play? That's something we should decide. So for me, if I look only to the lateral, I would ask you, if she bites down, what is the overjet dimension in this case? There's a reason for asking that.
And also, if I can add to this, probably this implant was positioned when she was way younger, because I can see that the length of the implant crown is definitely shorter, so it looks as if there's been an eruption, a passive eruption,
Definitely.
right, of the natural dentition. So, Francesco, what do you think? I mean, and this comes also into the...
Well, I think that this is the perfect nightmare cases, because firstly, I totally agree with the point that you highlight, but my question to myself as a periodontist is, which are the elements for saving the implant, or try to do the best from a mucogingival standpoint, or which are the elements to extract?
Yes.
In your opinion? Okay.
When I sat down with my brother, from his point of view as a prosthodontist, this is exactly what he said. But Jose, did the patient mention only the lateral incisor, or she mentioned her smile? And if this is the case, it's going to become easier. And I think Luis, she mentioned the whole smile.
Okay.
And so then the scenario becomes, I'm starting to think on probably crown lengthening according to her smile line. And so a digital wax-up suddenly comes into our mind, and so then Luis is going to demand me, where can you reach, how can you do it? And as Francesco is saying, of course, Francesco, we got to that discussion and to that point. So Jose, the mucosal margin of the implant is here. How far coronal can you go? Where can you position it for me? And
it's very comfortable to have a brother prosthodontist. I mean,
and I said, show me the digital wax-up, and I'll tell you how far, how close can I get. But as you were saying, and you see the perio point of view is already looking at the distal, and I mentioned it already, the distal of the central incisor, and it's certainly in the PA, in the periapical attachment loss. And this means that we have a limitation. The papilla is not as high as we would like to, and we have a limitation there. But we also realized that the crown seems to be quite over-contoured towards to the buccal. And we've learned throughout these years that if we wanted the mucosal margin to be displaced apical, we would increase...
Press.
Exactly. Apply pressure and increase pressing or whatever in the temporary. And if we wanted it to be moved coronally, then we would remove and generate a concavity. So we both realized, and I went with a probe, as you guys can, Isabella, imagine. I went with a probe to see how far the abutment of the implant is and how much space do we have to move that. And yes, from there we went.
Let's say we're not looking at an implant crown, but this is a flipper. Would you treat it differently in what you did? You're going to show what you did to this case. Does it matter there's an implant for what you're going to do to it?
As Vivianne said, with this aqualingual palatal position, quite similar.
Yes.
Certainly, yes.
Yes.
Certainly, yes.
Does that help you making the choice of keeping the implant or removing it?
I have to say that if this implant had too excessive buccal angulation, we are more into removing it.
Okay.
But I think what determines a lot of our decision is the buccal palatal position.
So if I may summarize, your first decision, like Francesco asked you, what is the decision, the criteria to keep or treat, am I correct? To keep and treat or remove is the 3D position of the implant in terms of apical height, because obviously you want to have enough space to create the soft tissues, but not too much, and mesodistal. Am I correct?
Yes, and the buccal angulation.
The angulation, okay. Fantastic. Are there any burning questions from the audience? I already have a question on this case with a possible solution.
Okay.
Which would be, which I'm going to keep for later because I wouldn't want to spoil this.
One question from my side. Do you believe that treatment plan may be different if conditions from adjacent teeth are different than this? I mean, in case of perfect adjacent teeth, the treatment plan could be the same?
I fully agree, Francesco. She has a beautiful smile. Other than the implant, the gingival margins located at the CJ or the smile line does not allow for crown lengthening of the neighboring teeth. Then the mucosal margin of the implant has to be in its ideal position. This means that probably we are more into explanting the implant. Good. Certainly, yes. We were helped by the prosthodontist and the more holistic, complete treatment planning, I would say. Yes.
Okay.
Fantastic.
Great.
Just that I understand it correctly, this is a screw-retained crown at the moment? Or is it cement-retained on an abutment?
It was a cement.
Due to angulation, probably? Or because on the CBCT it was not that bad.
No, it's not that bad, you can tell.
Yeah.
It was cemented and it was way over-contoured on the buccal. And now, if I'm allowed, you'll see the first thing we did.
Yes. Let's now have a look at how you treated it, please. Thank you.
So exactly, we started communicating by each other, and Luis said, let's do a digital WhatsApp, and I mean, not too fancy, but something realistic to see where we are. And let's move that into a mock-up and see how far we are, Jose. And when I saw it in mouth, I felt that it was somehow realistic. I could achieve by moving the mucosal margin coronally, a situation that would accommodate the patient and would make her happy. But this digital WhatsApp, according to her smile, you see requires crown lengthening, static crown lengthening for the neighboring teeth, then veneers or crowns, certainly, and a mucogingival surgery on the peri-implant side, on the buccal side. I want to get your attention on this. The very first thing we did is just removing the implant crown and placing a temporary with the CJ exactly where we wanted to, according to the digital WhatsApp. And look what happened with the mucosal margin. Nothing is done more than understanding both perio and pros, where are we going, agreeing with the patient, and changing the final crown to a temporary. Look where we are. What could have been a very challenging in terms of coronal displacement, which is the main challenge we do have, has become mostly a horizontal augmentation, which is predictable. And of course, yes, a little bit vertical, but not as much as I thought before. So at this point, said Luis, so I'm starting with the advancement and thickening the tissues of tissue augmentation around the implant, and then we will do static crown lengthening afterwards, according to the WhatsApp, to the digital WhatsApp, but understanding how did I finish my surgery. And close view of on the day of the surgery to what I'm facing, and I wanted to show you this picture because this shows the limitations we are having. And I'm not having many limitations on the distal of the implant. You see, its papilla is filling the interdental space, but I do have limitations on the mesial, and that papilla is very sensitive to be touched, but at the same time, I want to displace coronally that area the maximum I can. So this is going to be the hardest moment or point for my surgery, and I really wanted to present this case because it's not a 100% of fantastic case. It does have some limitations that I will share with you, as many of these cases do have some limitations. So I went to the tuberosity and I harvested this connective tissue graft that is rather thick. Why tuberosity? Well, we know that the amount of submucosa is very limited and the amount of lamina propria is large. It has very little submucosa at the area, and it seems to be stable over time. And we are now finalizing the 5-year follow-up of our study, classical palatal tuberosity, and this is the tendency we're seeing. It's rather stable over time. So Around implants, we normally choose tuberosity. Around teeth, we don't. We know that tuberosity cannot be exposed, so there's a need for coronal advancement. And since now some years, we've been working with the Vista design just by generating. We do normally one vertical incision, small, in the mucosal side, so way apical, and from there we help ourselves displacing coronally the flap. And from there we also undermine the connective tissue, and you can tell by the sutures and blocking the interdental spaces of the temporary, we aim to get the maximum coronal advancement we can. If I may say, and if I had to do this over, probably I tried to be too ambitious on the mesial papilla, and I was not too realistic, but I probably sliced it, and the adaptation and the suturing is not perfect there. And you will see that this compromises the early steps for healing, and it takes months to recuperate, basically, the mesial papilla of the implant site. But in any case, I was able to get a nice advancement, coronal advancement of the flap, and you can compare the before and after with the limitation of the mesial papilla. And I am expecting from that tuberosity, soft tissue to remain stable and to induce somehow keratinization as well. So early steps of healing, in which, and before the static crown lengthening of the neighboring teeth, in which we can see how we have gained horizontally what was needed, and sometimes even too much. But I, at this point, felt I had failed on the papilla, and I'm telling you that was the trickiest part, and today I would have been better in that sense. We went for guided crown lengthening according to the initial wax-up, and I want to say that probably my brother did not trust me that much in the coronal advancement or the displacement of the mucosal margin around the implant, because the lateral incisor 22 in this case is a little bit too high, or quite similar to the central and the canine, and you'll see the end result. But it's fine. It's nice to be guided these days. We can do it. It becomes very trustable. But you can tell from the early phases of the crown lengthening healing that probably 22 is a little too high. In any case, mucosal margin is healing and developing, and the papilla seems to be rebounding a little bit, and this is exactly what we have done. Only by the temporary and modifying the contour, the buccal contour, we have achieved displacement. Only by that, no surgery at that point, and then we had done the connective tissue graft from the tuberosity with the Vista approach, and then the static crown lengthening. The scenario seems to be quite different. Luis had prepped the other teeth, the surrounding ones, according to the wax-up, and this is where we are moving from that scenario to this scenario. And I'd like to tell you that, of course, the patient is so pleased with the result, and you see her smile now. But I like and I push our residents to look very carefully and in a very critical manner our cases. And I'll tell you, yes, papillas are developing mesially to the implant, and number 22 is at the same level of the canine. It could have been a little bit shorter. Case, I think it's fine, and she's very happy. But look, that if I were to do it again, although going against my heart, probably I would have compromised the papilla between 21 and 22. I'm looking at the prosthodontist because oftentimes my brother is asking me to just remove part of the papilla, which for a periodontist is like breaking my heart. But you can tell that there is this clear discrepancy between the papilla of between 11 and 12 and 21 and 22, and some other times we've done it. I didn't do it that time, and this is where we started, this is where we finished. So again, changing a final crown for a temporary, subepithelial connective tissue graft from tuberosity in the number 12, guided static crown lengthening, and veneers crowns for the neighboring teeth. Clearly, we have been of help to the patient. And now we are open for the discussion. I'm sure there are plenty of questions. I think I've been critical enough with the things that today I would have changed or tried to do a little better. In any case, I think we leave it here. Thank you very much. Thank you.
Oh, beautiful case, Jose.
Thank you.
I think that, again, as this is a very controversial case, means that, the reality can be assessed from different point of view. For example, one question that can be considered is, what about potential orthodontic treatment? Adhesion teeth, intrusion or extrusion, or what is the cost-benefit ratio, for example?
I think this is very important in terms of question, considering the biological cost of obviously creating veneers on the other teeth.
Absolutely. We had that discussion with her, and ortho is a very, I think, helpful tool for these cases. It is true that probably we influenced her by saying that we could achieve something like this just by involving pros and one surgical intervention. And she had had several treatments before because of her agenesias in the past. So since very young, she was in the dentist. And with not a lot of success, as you have seen. And probably as she was exposed several times in a dental clinic and spent chairside time quite a lot, she was reluctant to do ortho, and she decided that if we could achieve it by just a prosthetic treatment, she would be pleased. But I think it has to be offered, and our third sister is an orthodontist, so she's there, and we try to involve her, but the patient preferred not to.
May I put on the table also a perio question, I will say, because
yes.
You did a lovely surgery, and I know from some inner voice that you are doing a beautiful systematic review for DFP and this kind of surgery. But what about, in your opinion, is the stability, I will say, of achieved outcomes? Not probably in terms of root coverage or implant coverage, but in terms of maintenance of very deep surgically created tunnel, in your opinion? I know that it's quite difficult to understand data.
Yes, but thank you for the question, Francesco. We have reports up to 22 years with average of 11 years, stating that where we get at 2 months, which is normally we consider the complete healing, remains stable in around 90%. But I would say, and you might agree with me, that this depends really on the side of the mouth you're treating. And the lower anterior, it's a really challenging case and behaves very different from the maxilla. I have published long-term, short-term follow-ups in this area, and we've seen more receding outcomes than the ones published. So depending on where you are, for instance, the mandible, we try to get a thicker connective tissue graft and make sure that the advancement is the muscle tension is very, very well released, so that the body does not have the tendency of pulling down again. Because for the mandible, yes, we see more recession over time. And so the quality of the connective tissue becomes, I think, very, very crucial, very, very important.
And because we're speaking about connective tissue, I have some questions from the audience regarding the choice of inserting, as you mentioned, not only from a apical portion, so tunneling. Why did you keep, for example, the crown on the implant rather than creating more of a wall technique that we've seen during these days and covering everything to increase even more? Is this a choice? What was your decision-making process?
Yeah, thank you, Isabella, for the question. I missed to say that when I meant I would approach the papilla, the mesial papilla, in a different manner, I would have extended my connective tissue not only on the buccal, but trying to, yes, insert a little bit as well from a tuberosity below the papilla. Okay. Not with limitations in the coronal displacement, because she's coming from a failure.
Yeah.
Am I want to bet or risk a lot? No, I'm not. My tendency is to do what is predictable in our hands, not to fail again, because she's coming from a failure. My concern, my respect for the patient is that I know, we all know how much they suffer let's try to do something that maybe we don't get to the 10, but at 8.5 is enough for her, but we are not going to fail anymore. So gold standard, I think, is that yes, we could have risked a little more, but guys, it becomes tricky. Managing that area becomes very tricky and higher chances for failures.
Exactly. So I think we will touch about this topic with all three of the speakers, because when we were preparing this session, we said, let's remind ourselves that these patients are coming with a failed treatment, sometimes multiple failures. So we need to understand, as you said, you're right, we need to accept for ourselves, for the conferences we give, and for the patients, perhaps a semi-perfect result, even though your case turned out to be absolutely beautiful, but without risks. So this is something that I will probably ask.
If I may say last thing, if the implant has a lot of, you see, I keep the temporary because of the help that it provides us with the suturing, yes, and because we had created that concavity that allows me to work, and I can insert the connective tissue through the vista or through the sulcus with no issues. We had a space. If not, if I don't have a space, yes, we have to remove it.
Great.
Fantastic. Okay, thank you very much.
Thank you,
so now we will move on towards the surgeon. And we will see a different perspective. So Professor Vivianne Chappuis, the stage is yours from the University of Bern. And please welcome Professor Chappuis on the stage. Thank you.
So dear friends, dear colleagues from all over the world, thank you very much for being here. Thank you for the invitation to such an exciting topic, keep and treat or remove. I think this is a very, very challenging question. As you just have seen, the discussion is not straightforward, and we should not forget the patient and the frustration he comes into our office. We need to provide him with predictable outcomes. So today I brought you a patient I treated together with our perio department with Professor Gianni Salvi. He referred the patient to me. His name is Roland, and that's how he presents. He is 54 years old. It's a male patient. He's very healthy. He doesn't take any medication. He has no allergies. He's a non-smoker, very important. He has a medium smile line, and his wish is really to have a stable situation again. So when we summarize the patient-related risk, we can say they are low. When we look into the dental status, the patient is periodontally healthy except for the tooth number 22 and 23. He complains that number 22 has become a little bit loose, and he has some pain here and then in the region 22 and 23. The probing depth around these two teeth was 9 millimeters, and around the implant as well. You can see or estimate some bleeding on probing, and you can also see some separation from tooth number 23. And here I show you the X-ray, so you can clearly see a misplaced implant which was buccally angled. You can also see significant peri-implant bone loss of around 50%, but also significant attachment loss on the adjacent teeth, especially on the tooth number 22. In addition, we have the implant touching the root of number 22 as well. So now the question is, should we keep and treat or should we remove? So let's summarize the fact of this case. So we have peri-implantitis, which is very different from the previous case. We have significant peri-implant bone loss and significant attachment loss on tooth 22. We have a misplaced and buccally misplaced implant. We have an injury on the apex 22, and we have tissue damage on both adjacent teeth. So there, Gianni Salvi took the decision to remove also tooth number 22, which had increased mobility, and also the implant 23. So when we remove such an implant with severe peri-implantitis, what can we expect from the defect? And that's when I received the case. And you can see how the case presented after healing. So we have significant soft and hard tissue deficiencies, and now we have to think, how can we regenerate in the best manner for the patient, which certainly has a high frustration level due to the failed situation. We as well provided a wax up in order to visualize the defect. It also helps to discuss with the patient what is feasible and what not. So what I learned from Robert Schenk regarding regeneration of a defect is the regenerative potential of a defect really depends on the defect morphology. So when we have a four-wall defect, such like an extraction socket with a thick buccal bone wall, we have a high potential defect. It has a certain self-regenerative capacity. But the less walls we have, the much the regenerative potential decreases. And certainly in Roland, we have a one-wall defect. So when we want to regenerate the hard and soft tissues, we really need to think, what can we use? Because we need grafts with a higher regenerative potential. But there is always a backside. We have to harvest those grafts. And those grafts also oppose certain operative risks. So the higher the regenerative potential, the higher also the risk for the patient as well. So let's look at the option. So we could start with an autogenous bone block from an extraoral harvesting site. We could reduce morbidity by going into an intraoral donor site for an autogenous block. You can also use bone chips using GBR techniques with non-resorbable membranes or meshes. Then we can go to allografts, bone substitutes. But we could also think of using a small diameter implant, maybe allowing a simultaneous approach in such a case. Or we could think of using pink ceramics, or also just use something removable for the patient. So for our solution, we have to think about the invasiveness. We want to minimize it as much as possible. And on the other side, on the regeneration we want to achieve, and of course we want to maximize this, but we have limitations. We have limitations through how many surgeries the patient wants to go, and you will see as well, it will not be the perfect solution in this case, not the perfect result, just because the patient is really much more concerned about the function of his teeth and not so much willing to go through too many surgeries. So this is my case, and I'm looking very much forward to my colleagues, what kind of solutions they have for us. Thank you very much.
Thank you.
Thank you, Vivianne. Thank you very much for a challenging case.
I think, Vivianne, could you clarify, I would say, to understand better the reason for the extraction of lateral incisor? Because you quote that there was an advanced periodontal lesion, but I was thinking to periodontal treatment or endodontic treatment. Could you clarify?
Yes, so there was just a significant tissue loss, like more of 50% of the root, which was no periodontal ligament anymore, and there was probing depths all around the tooth of 9 to 6 millimeters. So it was decided due to the severe infection that this tooth could not be maintained. As you can see, there is also attachment loss on the central incisor already. After extraction, there is a recession on the distal side. So due to the defect, it was decided that tooth number 22 has not a good prognosis.
Yeah, but I'm sorry, but basically, this complicated, I would say, the overall treatment plan, because, the implant treatment of 2 missing teeth is worse than a single one. So I think that it's a very difficult case, and I think that probably the decision-making process on the lateral incisor may be crucial for understanding, again, the dimension in this case.
Certainly we can discuss if the tooth number 22 could have been maintained, but I'm pretty sure that we will have a significant vertical deficiency on the distal part as well, and then we need to think about the aesthetic, because we will create an asymmetric or a more asymmetric situation.
So if I understand, you select to do this kind of the tooth extraction mainly for achieving better aesthetics due to the fact that you started with a deep loss of interdental or distal attachment.
Yeah.
If I understand.
And we should not forget the patient. The patient was really concerned in function. He went through treatments again. He has pain. So he wants to have the least amount of possible surgeries.
Okay. Thank you.
But did I see well? But on the X-ray, it looked as if the implant was touching the apex of the lateral. Am I correct?
Yeah. So there was some injuries of the implant to the lateral as well. So that's why, and also was endodontically treated. So that's why the lateral was removed.
Would you justify taking a CBCT scan to assess this? Because obviously in a two-dimensional layer, you're not certain that this is happening. Would you do this as from a diagnostic point of view, or do you think it would be an overexposure?
I think if you are not sure if there is a buccal wall maintained, you should do a cone beam CT. But from the clinical examination, it was clear that there is no buccal bone left.
Okay, no, because this is interesting, because this would be the typical conversation in a practice saying, what would we be doing to be able to assess every aspect. From a prosthodontic point of view, what is your gut feeling?
I'm thinking when I look at the case, what would be the ideal outcome? So if we think in our minds, placing a lateral incisor and a cuspid there, how big is the defect we have to regain? And then the question from a pros to a surgeon is it possible from this point of view to at least have augmented it buccally so that we have a normal flat ridge? Would that be possible for you?
Yeah, so the good thing here is that the vertical deficiency was limited, and what we can predictably augment is horizontally.
Exactly.
So
yes.
We have a quite good palatal bone wall, so we can augment horizontally. And certainly we can discuss how many implants we should place in such a situation, and which could be more favorable if we have a cantilever situation.
Yes, that's what I was thinking. For me, as a pros, I would say, when you look back to studies from Garba and Salama, for example, if you look to papilla between implants and papilla between a pontic and an implant, the last one is much more favorable.
Yeah.
So in my mind, I would, if it's possible, would place an implant on the cuspid position and then cantilever to the lateral due to the small leverage arm.
And just to inform you as a group, we have received from the audience several different options or ideas, and this is exactly the point of why we're sitting here, because we see one case, which is an extremely realistic case of the cases we see on an everyday basis, and yet we are in a sophisticated group of delegates and people sitting in a room, and we have something like 10 different options. So can we address and I think, Vivianne, you will show now how the treatment has been carried on, but I think we should really give some guidelines if possible, or at least can we address what are the indications that then puts us towards one treatment versus another. Because there's also the option of keeping the implant and treating the implant, for example, and working on soft tissue management. So let's then explore all the options, but I don't want to take time away from your presentation.
I was going to say, from a perio point of view, and I'm sure somebody has thought about it, that, and Vivianne explained it well, if the patient did not have static expectations or a smile line, I am trying to save the implant and the lateral incisor, understanding there is probably attachment loss way more important than where it is now. And so clearly sequela of periodontitis and periimplantitis, but I don't know, the defect maybe had a potential, and I would, but again, low smile line, no static expectations, and it was not the case. I understood.
I think it's time to see what has been
Thank you, Vivianne.
carried out. Thank you very much.
So how solving the case was actually what we heard from the prosthodontists, to re-establish the ridge horizontally. It will not be perfect, but to go for one implant with a mesial cantilever in order to optimize the situation in this way. So we went for an autogenous block. We measured out, we performed a mucoperiosteal flap, normally with only one releasing incision on the distal. This reduces morbidity and flap stability. Then we go to the retromolar side whenever possible, because this provides less morbidity for the patient. You can do this certainly digital with your planning, but we used the perioprobe. You can measure quite exactly. You set the marks, and with the piezosurgical tool, you really can use fine osteotomies. You nicely can control the depth of the bone you are removing. And then we go to the recipient side, so we perforate the buccal cortical bone in order to enhance vascularization. We stabilize the block with 2 fixation screws, and then we fill in the voids with small autogenous chips in order to enhance further the situation, and very important to protect the autogenous bone by biomaterial with a slow substitution rate, and then covering the site with a collagen membrane, resorbable. We fold it underneath the palatal mucoperiosteal flap. We always enlarge the membrane to the pristine sites. So normally no tags are necessary, but you certainly can use tags in order to stabilize it even further if you have any doubts for the stability. Then the next step is primary wound closure, very important. And then as well, make sure that you have no contact from the provisional restoration. I always aim for 1, rather 2 millimeters. And we always ask the patient not to wear the provisional for the next 2 weeks, when the swelling will be quite significant. The patient receives antibiotics for 3 days, and then we check if we have hematoma formation. If yes, we continue antibiotics and analgesics, of course, and a chlorhexidine rinse. In addition, those patients always get a pressure dressing from the upper lip in order to help with the swelling as well. And then we normally remove the sutures after 2 weeks. So then we let it heal for 4 to 6 months. Here you see then the result. With a surgical guide, you see that we could increase the width of the crest, which allows us now to insert an implant. You see when we reflect the flap, due to the screw heads, that we did not have a lot of resorption of the autogenous bone, so the augmented side could be very nicely maintained. We remove the fixtures, screws, and placing a standard implant 10 millimeter in length, 4 millimeters in diameter, in the canine region, using a surgical guide in the correct 3-dimensional position. And then we are aiming for a hybrid design implant with a polished neck design, bringing up the implant shoulder with a vertical platform shift away from the bone in order to preserve the bone as well, and also to be more manageable in case of a future mucositis. We slightly regrafted the site, let it heal for 4 months. Then we had the insertion of the healing cap, and then the restorative work was done by Professor Salvi. So now what you want to know for sure is this predictable? Because this is a treatment which nearly takes 1 year until it is finished. And we need to provide the patient with a good long-term outcome. So we had a study exactly on those kind of treatments in 52 implants after 10 years. So we measured the amount of horizontal bone augmentation before surgery, during block augmentation, and then after 10 years using a cone beam CT. And you can see that the bone gain was nearly 5 millimeters. And what is important is that we had only minimal bone resorption after 10 years of 7.7%. What was interesting to see that the recipient side, maxilla or mandible, did not influence the resorption rate. But what was a slight difference is that the ramus graft slightly resorbed a little bit more, but still with providing less morbidity for the patient, this would still be my treatment of choice whenever possible. So we had very stable peri-implant bone levels, leading us to a success rate of 98%, so very similar to pristine sites. On the right side, you see the patient with a failure. It was a smoker. The implant was replaced, but the patient could not stop his smoking habit. So you see on the newly placed implants still a little bit more advanced remodeling, but the implants so far could be maintained. Now you certainly want to see how Roland is doing after 10 years, and I can show you the result after 10 years here. So he still has a medium smile line. The probing depth around the implant is 4 millimeters. You see very stable peri-implant bone levels. And very important, he is really in a regular maintenance program. He comes in regularly. You can also see how we were able to enlarge the horizontal bone crest We were discussing to do a soft tissue augmentation, but you can see that the patient has a thick soft tissue phenotype, so we decided in a first way to just observe and to see how the tissues changed over time, and then at the end we decided not to do any soft tissue enhancements. So thank you very much for your attention. I'm looking forward to the discussion.
Thank you, Vivianne. This is, in my mind, a beautiful case because it's a beautiful case from the reality, as it's not an Instagram case or an artificial dentistry case. And I really appreciate your, highlights on the gingival recession, no root coverage, because simply there was no request from the patient. But I'd like to understand what is, in your personal opinion, your big experience in guided bone regeneration, what is your feedback regarding soft tissue augmentation after GBR? Do you think that there is some indication? Do you think that in this kind of surgery, some soft tissue augmentation may help, for example, aesthetic outcomes or long-term maintenance? What is your feedback?
Yes, of course. I think in this case, I think it was really at the limit. And if I look today at that case and the experience we have with soft tissue augmentation, where we exactly know where to take the grafts, where we know better now that these grafts also are stable, enhancing the soft tissue sites, I think, yes, I would today consider a soft tissue graft, maybe also to help the prognosis on the central incisor. Yes, yeah. For sure.
Can I ask, because can I call you the queen of GBR? Because I mean, you are an expert in this topic, and you have published and shown really beautiful results. Was it the decision criteria to use a block versus a traditional GBR? Why was your decision to take a block rather than the GBR, traditional, let's say, GBR using, for example, a non-resorbable membrane? Do you have any indications on?
So what we felt is for the non-resorbable membranes, in such a case, when you have a previously failed implant, you have a lot of scar tissues, and the tissues are not so elastic. So I think we have a higher risk of dehiscencies if we would use a non-resorbable membrane, because it's just the tissue management is just much more challenging. So that's why we change to the collagenous membrane resorbable ones in case we have a slight dehiscence. This is much more healing in a favorable way. So that's why we didn't choose to go for a non-resorbable membrane.
Yes, because we were discussing this earlier, and these patients come after multiple failures. Yeah. So we are the people who, probably the last call when they rely on our treatment. So how do we manage also the pressure, psychological pressure on ourselves to be able to deliver something with as low possibility of failure as, for example, Jose, you were saying exactly the same thing. I'm not going to do anything extreme to avoid failure. So we are in line with this.
Yeah, exactly. So I think really when we look at this treatment, we really have to be sure what is feasible in such a case, because we are dealing with another environment. If this would have been a pristine case, that the options would be much different. But I think here we really should aim and strive for safety and predictability, and not, would I say, that change the border or go over the border too much, but really stay within the green zones.
Yes. Do you have any questions from?
Yeah, one last was, I was thinking, look at your beautiful case, and I was thinking that lateral incisor, of course, had some periodontal infection, but it's a single-rooted tooth, so that can be treated, I think, quite good. What about a root submerge technique to keep that part of the ridge more stable? What are your experience on that topic?
So you're talking about the central incisor?
The lateral incisor. It had some periodontal issues, but I think a single-rooted tooth can be treated properly. What about a root submerge technique in that area and then graft on top? Then you have more volume. Just a thought process. If it would be a high aesthetic case, because now he's not showing, but if he starts smiling and you see everything, then maybe a patient wants a next step.
Francesco was saying that having an issue with a single tooth is, aesthetically, it always has a better prognosis or outcome than living with two missing teeth. And so just preserving the root certainly preserves the ridge. Now it has to be left with no disease in the roots. And yeah, the implant was, I think, touching a little bit and so the scenario it's a little bit messy, but if periodontitis can be controlled on that root, then the explantation of the implant and simultaneous grafting might it's something that we would consider these days, might give you then an implant placement just with soft tissue grafting in one shot, maybe, you know. But it's difficult to say when you...
It's a very difficult case.
Difficult to say.
And it's so lovely.
It's a very difficult case,
Yeah.
I mean, to be able to achieve.
We also have to think when you have the attachment loss, where is the regeneration coming from? If we place an implant, then we just have bone and tissue on the buccal and lingual side. There is not too much from the implant, of course, and also from the tooth. So I think regenerating such a site, in my experience, is very challenging. So I thought regenerating the bone for both sides made it a little bit more easier for the demands the patient had.
And Vivianne, this case was treated more than 10 years ago because you correctly showed a very long-term follow-up, which is great. Today, with all the knowledge we have of, for example, the use of biologics, would this have changed your decision process, or would you have done exactly the same?
Of course, it would have been changed. So I think we would have more critically discussed like the lateral incisor, what kind of options would we have there? We know much more about ridge preservation. Could we do something when explanting the implant to preserve the ridge in order to have a little bit more tissue at the end? Maybe it would have been possible today to maintain the lateral incisor.
Fantastic.
Great. I think that
it's intense because we're seeing cases that are difficult to manage, and we're trying to find.
It's also so lovely. I mean, to
real.
Listen that so incredible speakers are able to discuss in details the beautiful case, saying that sometimes I can think to something of different.
And I want just to tell the audience that the speakers have not seen the cases before. So this is a complete, brand new moment for them. So their reactions are completely...
It's much more a sociological experiment.
It's a sociological experience. Okay, then let's carry on with the sociological experience.
Okay, thank you, Vivianne. But now I think it's time for the speaker number 3. He is Martjin Moolenaar from the Netherlands. So I think it's time for taking a view from the posto.
Thank you.
Thank you
and welcome.
Thank you, Martin.
So, dear colleagues, it's a privilege to be here and sharing the next case with you. I introduce Anne. Anne is a young actress in the Netherlands, so aesthetics is very important to her. And she had already received a lot of treatments. She's 24 years old, and she had 3 years ago a bike accident. Lost one tooth, and when somebody calls the office with an accident and loses tooth, you know something happened in that mouth, and that's the buccal plate is gone. And that's important when we look to this case. And then they start treating her, not at my clinic, but she was referred to me to improve her crown already on the placed implant. And what did they do to her? They gave her first an orthodontic treatment. What made sense in this case? Additionally, they gave her a bone augmentation, placed the implant with a free gingival graft harvested from the palate. That gave some trouble. So they did an extra surgery to try to solve the problems with the soft tissues. And then they made a provisional crown. Periodontally, she's healthy, medical also, no problems, so that we have to know when we start treating her. So let's take you a little bit through the case. This is her smiling, and when we zoom into the smile, you can see some problems, at least from a prosthetic point of view. I see a canted midline, I see not an harmonious smile, it's a little bit off balance, and of course we see the provisional crown, but that's no problem. We have very talented ceramics who can make nice crowns for us, right? But it's also interesting to know how the treatment went before she came to my clinic. So look to the history of the case. I could get my hands on some photos because a very good orthodontist treated her for that team. So this is the initial situation. We can see that she has slightly debite. We can see that her lateral incisor is half restored with composite, and maybe is out of position. I don't know. I cannot see in the history. They didn't write down if the tooth was dislocated due to the trauma, yes or no. Also, when we look from an incisal point of view, we can see there's a big defect on the facial incisal part of the alveolar crest. That's the aesthetic part of that implant. So what did they do? They gave her a bone graft, that's okay. They gave her soft tissue graft, and they placed an implant. And this is how it looked. The thing floating in the air, I think, is a soft tissue graft. So things went south on this case. Also, maybe oral hygiene is a little bit on the poor side due to post-surgical phase. So what did they do? They thought, okay, we have a problem. So the solution to the problem in that team was a coronally event flap in this situation. So they performed another surgery, and this is the final outcome of all the surgeries they've done. So now they removed the brackets, they did the coronal advancement, and this is after healing. And then she was sent to me. They placed a professional crown on that implant. And this is the first appointment in my clinic. So I took the photos and looked at her, and then now we have to decide what to do. What can we do? Because for her, aesthetics is crucial. She said, what can you do for me? And when I look to the implant, I already see some bone loss. And you can decide if we can accept that or not. We have to decide from a restorative point of view what we can do, but also from a biological point of view what we can do. Because we have an asymmetric smile. And the situation as it is now is not acceptable for her. She wants to have some improvement. But due to all the treatments she's already went through, she's a little bit reluctant to have another surgery. So we have to be sure what we can do for her. So that's very challenging. So this is the case. Here I have the periodontal probings for the additional information. No big problems there. The X-rays and the intraoral view from where we are standing before we started treatment.
So,
it's a headache. Bless her, she's 24 years old.
Yes, that's
and yet she received multiple surgeries,
yes.
Ortho treatment. So here, you need to put a hat on of the person who brings her the result without basically doing much.
That was the question. That what can you do to improve the situation with the less possible dentistry and harm to my teeth? Well, that's of course an issue. So when I have a problem like this in the clinic, we have to look from the biologics point of view, what are the numbers from the periodontal probing and what can we expect from the body in a young person, and from the restorative point of view. And that we have to discuss with her, and then we have a treatment strategy.
I'd like to convey in the discussion, Vivianne and Jose, do you think that in a previous surgical procedure there was something that can explain the complication outcomes, I would say? For example, plaque control?
No. Sorry. It's a question to them and I respond, it's not fair. Go, carry on.
So please,
Yeah.
I think it's very important to try to distillate the direction.
Yeah, so I was wondering when I saw your case, what failed when they did the soft tissue and the bone grafting, because this was a young, healthy patient. We have a single tooth gap. There was attachment on the lateral incisor before and afterwards. There was some kind of an infection which really led this case in going south a little bit. So I was wondering what went wrong in that augmentation procedure.
This is, of course, I don't know, but
Yeah.
I had the same question in my mind. So I looked at the case pre-orthodontically, and I looked at the scallop of the lateral incisor, and I thought, okay, if you bring that tooth into position, you have two nice soft tissue scallop tooth. And the papilla, you can suture your soft tissue with a coronally advanced flap, correct? But there are two things that could help in pushing this case in the wrong direction. One is, of course, orthodontically, they move that tooth. And if you look to studies, for example, studies published about orthodontic eruption, if you go in too early with your surgery, the bone didn't follow yet, or the stress is not out of the soft tissue. So maybe the orthodontist moved that tooth into position, and the surgeon was thinking, okay, now's the time to go in, but he had to wait to get the soft tissue mature and the bone to fill in. That could be a problem. Then if you open the case and close it back, then the damage has already been done to the case. And then it heals like this. That could be what happened. I'm not sure. If I look to the case, then I think, okay, in such a young lady, we have, at the palatal part, we had enough soft tissue. So why not place that implant? That's okay. Maybe do your bone graft, maybe soft tissue graft if you want to, and then close it completely. Not place the healing abutment. Don't make that opening to the intraoral environment and have that risk. That could be, but hey, it happened. So maybe you have a different thought on that.
So sometimes we tend to be a little bit unrealistic when dealing with papillas areas. And guys, everyone knows it's so challenging. It's so challenging. We see Giovanni doing it, Martina. For the rest of the human beings, it's so challenging. Let's be realistic for one time. And you need to be so sure that the patient is understanding the risks for the procedure. And yes, plaque control was not ideal, and maybe the distance between the implant and the tooth is too close.
Yeah.
Maybe an open environment with a healing abutment is not the ideal. Maybe, splitting the papilla is not for the rest of the human beings, and we need to use, faraway incisions and tunnelize. But it's really very, very difficult, I think, for selected people. And now we see the failures, and this is happening in Holland, it's happening in Spain, it's happening everywhere.
It's happening everywhere.
Martijn, what is, when you see this, what is your first reaction? What is it that bothers you most? Is it the lack of the papillas between the central incisor and the lateral incisor? What is it from your gut feeling?
Yes, that's
and
bothering.
because probably you then need to address this in turn. And
I want to have some symmetry. And if I, from a restorative point of view, should restore this case, then the only option I have, make very long contacts.
yeah.
In a young lady smiling and wants to be on television, that's maybe not what you want. So I'm thinking, okay, what bothers me most? What bothers me most is the horizontal bone on the lateral incisor to the implant. I don't have a bony peak there. So I know that with playing with my professional restoration on that implant, probably won't bring back my papilla. At least if you look very closely to the case, you can almost not call it a papilla, but the distal papilla on the implant is better than mesial on the lateral. So we have a risk if I remove the provisional that shrinks back and it becomes worse.
Yeah.
I think we should see.
Yeah.
What?
We're really curious now.
we're burning.
So normally when a patient comes to the clinic for a problem, I don't have patients who come to the clinic and say, Martin, I really want to have an implant. You? They have a problem and we suggest placing an implant, okay? So what we do is we have a small protocol that we look first to the adjacent teeth. Are they in the correct position? Because that helps building the case, building the environment for that implant. Secondly, we look at what is the quality of soft tissue. In very thin cases, maybe we have to augment the site with soft tissue. Then we think, okay, do we have enough bone because the soft tissue is supported by bone? Or do we have too much bone? That's also sometimes a situation what can occur. So we look at where's the bone and is that in the correct position? And last but not least, we look to the whole picture in how does this case should look after treatment. So we try to envision this should be the ideal outcome. And then we can talk the patient through the process and talk the patient through the options and tell them what we can achieve and what not. We should be realistic. Yes, because on a computer we can design everything for a patient. But is that, from biologics point of view, realistic? So we have to be honest to our patients what we can do. So those 4 steps normally we use for a patient. But in this case, the implant is already been placed. So that's a problem. That's a problem. So if we analyze the case and I draw a line, then we can see we have a disbalance between left and right. Okay? She has a slightly long central incisors. We see on the implant it's a little bit too long, but the lateral is also on the long side. Also, we can see those open areas where soft tissue would have been, but it's not there. And am I the guy that will bring that papilla back to the ideal spot? No. From day one, I have to be honest to my patient. We do our best to improve it, but to get here the ideal outcome is extremely difficult. So my treatment, what I suggested to her is say, okay, first, if we look at the X-ray and we draw the lines, then that provisional crown is over-contoured. Yes? So the distance from the neck of that implant to the free gingival margin facially is very limited. Normally, we have more space. Yes, so my treatment would be for her, not for the papilla, but for the facial part, first recontour the provisional and see what happens. I always can go back. I don't think I will lose something. Yes. Then we re-evaluate, and probably I will force erupt the central and lateral incisor. They're endodontically treated, so we have some running room to do that, because I have to shorten them incisally. And then I think by the end of the day, we're going to make 3 ceramic restorations for her. So that is the strategy. So if we look to the old pictures, I wonder where is that mesial papilla between the central incisor and the implant, where it's gone, right? It was there. And it's like a balloon filled with water. If you compress it a little bit, it stretches, and you have a buccal papilla, a caul, and a palatal papilla. But now it's gone. And if I look to the facial soft tissue around that implant, that soft tissue is in need of some more space. It's compressed in the wrong way. Because if we look at the healing abutment height, yes, on the mesial part you see maybe 1 millimeter exposed, but on the distal part it's almost 2, 3, it's almost to the implant. So I say, Anne, listen, I have to make you less beautiful before we can start treatment. And she said, what do you mean? I said, I have to improve your soft tissue volume. At least I want to see what your soft tissue, how it will respond to this first step. It's a non-surgical approach. So we cannot lose anything. It won't get worse to you, okay? She says, okay. So I have to recontour the professional to see what will happen. And then we together reevaluate that part of treatment. And then we set the next step. She said, okay, but she didn't completely get the picture of what I meant by that. So this is what I meant. She said, oh, I'm going to hide whole summer in the house. I don't go outside anymore. I said, that's okay. Yes, because we want to see how you heal. 2 months later, this is the situation. This is free gingiva, non-surgical. And this is very favorable to her. It really pushed the treatment into a certain direction, because now we have a different starting point. So she starts smiling at me, and we have a different disbalance, but we're heading the right way. So I say to her, Anne, listen, this is very good what happened. She says, oh, that's okay. What is the next step? I said, the next step is again something that won't make you happy. She said, what do you mean? I said, I sent you to my orthodontist. She said, but I already have braces. I said, yes, but I cannot build papilla. Not on teeth without bone approximately. And the only way to bring bone down is by bringing those teeth down. And she said, I understand what you're saying. So you have to go to the orthodontist again. So we re-evaluate the case. Now we see we solve one problem, that's the implant. Not the lateral incisor, but that's easy to do. And maybe we're lucky by bringing down the teeth, bringing down those papilla in a better position. So there she goes. Back into braces. There's also a limit in what you can force erupt teeth and load them afterwards. Crown, root ratio, you have to be in balance still. So it's not force eruption in preparation for extraction, that's something different. So you can see here the gain we had before ortho and after ortho. And you see the peak on the lateral incisor and also the stretch peak on the central incisor. So it's an improved situation. Not perfect, it's improved. And now we have to re-evaluate again and say, Anne, you're lucky because we're heading the right direction. And if we now start analyzing the case, it's better, not perfect. It's still disbalanced, but not that much anymore. And from this point, we can tweak the situation a little bit. We can alter the soft tissue on the implant slightly to be more harmonious to the other central incisor. And of course, with restorative materials, you can choose whatever you want. We can restore the adjacent teeth and alter the form. And that is what we did. I always give big compliments to the ceramics who works on those cases because it's very difficult for them to make very nice crowns or veneers, what we did in this case, and layer them because I love the layering. It's, I think, more beautiful than monolithic, but there's a different discussion. And this is the outcome of this treatment. Perfect? No. Hopefully better. But she's satisfied with this. That's the most important thing. That's the most important thing. So if you look at the smile, this is 3 weeks, 6 months. We brought back a little bit those two centrals into the smile frame because we tweaked the soft tissue there. And to summarize the case, he came from a trauma situation, went to orthodontics, got the implant, went to altering the professional and orthodontics, and then finally, this is what we achieved for her. This is the 3-year outcome. You can see the papilla fill-in a little bit more stable. The X-rays to show you the adjacent teeth are still stable, and this is what we get as a final result for her. So I'm really looking forward to the discussion and the thought processes of my colleagues. Thank you so much.
Thank you, Martijn.
Fantastic.
Really a beautiful and realistic case again.
Yes,
beautiful
yes,
and realistic.
yes, yes.
And I think that it's very, very nice and important to underline, for example, the critical role of temporary prosthetic treatment.
Yes.
It's very important. And I think that all cases are connected by these elements. And another important element in our final discussion, I think, is the time. We need time, unfortunately.
Look, I wrote it as big as a...
Sometimes we give courses to, and we just wrote an article about implant dentistry in the aesthetic zone, and the title was "Time is Your Friend."
Yes.
Absolutely.
Because it is what it is. Don't rush those cases. In my experience, if a patient has an okay-looking professional screw-retained crown, they're happy. Wait and see what happens. You can play with that professional. You can play with the soft tissue, modify it, but if they have that screw-retained, their comfort, it won't go out. You know, they can eat with it, and then you buy time for that case. Because we need 3 to 6 months for stabilization of soft tissues. So take the time, because they want aesthetics for a very, very long time, so a few months.
Of course. I have a question regarding the, could you have achieved the same aesthetic results using direct composites rather than using from a prosthetic point of view? So being a little bit more conservative on the natural dentition.
That's a good question. Of course, the implant restoration is a ceramic restoration.
Of course.
Yes. The lateral incisor was for half composite. So then I normally choose ceramic. So then I would have 2 ceramic restorations and a composite on the central. Of course, that can be done. But through time, maybe you can see differences.
Okay.
So there's a discussion with your patient if they accept that from you or not, or that you say, okay, we have to repolish in 3-4 years. And if they're fine with that, perfect, because I know and I've seen beautiful composite restorations. So if you say that central incisor, could you have treated that with composite? Yes, definitely.
So I guess the question also for Vivianne and Jose, he has avoided completely surgery. No one has touched this girl from a surgical perspective. Do you think there could have been a room for connective soft tissue, because we're not talking about bone grafting or anything, but soft tissue augmentation in there? Or having seen how he treated, perhaps we should reassess the tools that we have rather than our training, for example?
I thought ortho was absolutely necessary there, and allowing for space for the soft tissue.
Yeah.
The soft tissue thickness was there, so I was never thinking
exactly.
of augmenting more. It was just giving a space. And we see these days with the BOPT technique that sometimes we are not needed, and we accept it. I mean, sometimes it's more on the prosthetic side, and this is exactly what you guys did, allow for space with the emergence profile.
Yeah.
I completely agree. I think there the space is so limited, 1.5 millimeter to optimize the tissue there is very, very difficult. But I'm impressed by both of your cases, just by slimming down the provisional, how much tissue gain you had vertically without doing any surgery. And I think when I sometimes look at these cases, we have these wide abutments which are really killing our bone and soft tissue management. We really should remember we should come slim out of the tissues, because this prevents the health.
Yes.
Yeah, so perhaps, Martin, you want to comment on, from a prosthetic side, to try to guide, for example, the audience towards using something that allows more space.
Yes.
So that this creates, as you said, you called it what did you say, a balloon full of water?
Yeah.
That fluidly.
Okay. No, the question is, how do you professionalize an implant, and how do you alter it through time to get to the very nice scallops you want to achieve? I would say start with a very narrow restorative component. It's a healing abutment, it's okay. If it's a temporary crown, it's also okay. It shouldn't have to be perfect the first day. And then, after 2 weeks, 4 weeks, I have an appointment of removing my professional and adding contour and see what happens. And most of the time, in 2 appointments, we're getting to the situation that we think, okay, this is okay, and then I wait the 3 to 6 months before we go to a ceramic restoration. Also, in the proximal area, an implant is different because it has no attached gingiva to it. So you have a longer contact, so you have to build that contact, and squeeze that papilla a little bit so you can squeeze it outwards, because the buccal papilla is in front of your line angles of your teeth, correct? If it's backwards, you get that shadowing in between your teeth, and it will give away that you have made restorations.
There is a question from the audience asking about the ortho extrusion, right?
Yes.
And they're asking, well, the result that you have achieved is significant probably for the overall result, but they have not seen such a massive significant result. So because we're talking about something quite difficult to perceive. So how do you justify this with the patient? Because they have to go through months of treatment.
There are two things. First of all, we trimmed the provisional, and the facial soft tissue on the implant came incisely. So the step to the lateral increased. And then we did the forced eruption. So we did quite a significant amount. You won't see it because the facial, the buccal gingivas improved. Yeah? Otherwise, we have had more scallop. If that implant soft tissue facially wouldn't move and we force rub down the lateral and central, we have had a bigger scallop.
If
That's
I
why
may,
you won't see it.
No, but this is, I mean, if I may, and then I'll ask Francesco to wrap up, but I want to just highlight how important, and we've seen from every single speaker, how important you showed the steps, the diagnostic steps. So every single case, whether it's a pristine case or whether it's these borderline cases, difficult cases to treat, we must assess them calmly, with time, interdisciplinary, sitting down and making sure that we have all the diagnostic and documentation that we need to be able then to process. And you mentioned how important, and you showed as well, Jose, the wax up. I had one question saying, but why did you do a wax up? The wax ups or the digital setups or every step is to pre-plan in advance everything, right? So can we mention this as one of the key factors to the successful treatment of these cases?
I totally agree, but I think also as a poor university professor, as educators as we are, that it's very important to share with the audience and to the young guys especially, that skill operators and learning curve are very important. And these beautiful cases that you treated require a lot of experience and a lot of scalability, unfortunately. So it's not a gym to try and to. This is very important, in my personal opinion, from an educational standpoint.
And also the honesty with yourself and with the patients, and we received some comments from the audience that they appreciated the fact that these are cases that we try our best. We certainly improve, but as you mentioned, let's not overdo it, because sometimes if we feel ourselves as superheroes, we end up causing the number 5th failure, the number 6, and this is unethical to the patient. So I think when we receive these cases, we're in a very difficult position, because we need to find the good balance of excellent treatment, yet predictable. I think predictable is the right word, right?
Yeah.
And with this, Francesco, I mean, co-chairing with you has been splendid.
Thank you, but I think that you did a beautiful job. And so we are really honored and happy to share the stage with you, and thank you very much again.
Thank you for your time and for all your efforts. Thank you, everyone.